Yes, welcome again to Third Park. We continue with our class. Today is a demonstration of the equipment that we have here. Hi, Dalton. So, just to briefly take you through the equipment, then we'll go on them one by one. This is all set up on boom arm, so you can see there is nothing hanging down there. I mean, it doesn't have wheels. This helps with keeping the theaters clean and more organized. This on the top rack, so it's called a rack, okay, or a tower. This rack, this has the endoflator, or this is the insufflator, which is for gas, okay? We'll be discussing it. This too is actually for it's a camera processor. It's a camera processor. So we have the 4K camera processor and we have a 3D camera processor in this theater. Then we have this as the light source. So this is power LED 300. So it's an LED light source. We'll go into that. We have a generator for shaver or moscillator, so this is a generator. We have this as an endomat select, that is for fluid. So the way you have something for gas, we have for fluid, which we use for hysteroscopy in our case. So there is fluid for irrigation and for suction. We have a smoke evacuator. Smoke evacuator is to actually evacuate smoke. I don't know of many places with a smoke evacuator here, but it's good to understand that a smoke evacuator is very important in the sense that it actually protects you against the carcinogenic smoke. What you'll see in many places, even in open surgeries when we are buzzing, the smoke is being inhaled by us, right? And it's not ideal situation, okay? And this last unit here is called the electrosurgical unit, ESU, electrosurgical unit. So it's the one that actually generates the electricity into heat that we use. So we'll go into these one by one. Hopefully we finish everything at once. Now, we start off with this. This is the camera processor, and this is the recorder. So here we have a recorder. So this records our videos, our pictures, and we archive these things. To complete the setup, since you're now inside theater, this is your tower. This is our lights. All right, so that is in all theaters. This light also has a camera, as you can see. Those are our monitors. So these are monitors. We obviously have large 32-inch monitors. And you can read up here, it says 4K 3D. So it actually is a 4K monitor when you're using it as a 2D laparoscopy. And it is also a 3D monitor when you want to do complex 3D procedures, okay? We'll see if we can demonstrate both 3D and 4K for you. So at the moment, we have connected a camera. So this is a camera that now is connected. So if you can see, that is already showing on the monitor, okay? So this camera is a 4K monitor. 4K camera, it's written here, 4K, okay? So it will tell you. So there are different things about cameras that you should know. This camera head has a couple of parts. It has a coupler. This is a coupler, okay? It has a CCD, which is the charged coupled device. CCD is this part here. And then it has the knob. So this is the knob. The knob is to connect to the scope. So this is There are different mechanisms of connecting, but this is now connected, as you can see, okay? So that's a connected scope. Clear? So what is important is to understand the coupler is actually acting like the pupil of your eye, okay? So pupil of your eye means it is the one that allows the light in and out in different sizes, okay? The CCD is actually where it captures the images. So that's like the retina, okay? So this acts as the retina, this acts as the pupil. The lens acts as your cornea. I mean, it's like an eye. This is an eye. You've understood? And then on top of that, you're putting your scope, which we've already discussed. So this is what I meant by 30-degree scope. Now, do you remember this? Can you see this angle? This is written 30-degree. So see, I'm holding it straight, but look in the screen. Look behind the screen there. Can you see what it's showing you? I'm holding it facing Doc here. Am I seeing you in this? No. I'm seeing 30 degrees down. Can you see I'm seeing my phone? When I just turn this like that, opposite, this camera view will turn this side. So now see, when I do this, I'm already seeing the camera and him on the side. When I turn this down, I'm seeing the roof. Okay, I'm now started seeing the light here. So now I'm coming back to this side. So please understand, when it's a 30-degree scope, when you're holding it this way, you're not showing me what's there. And that's what most people think, and that's why they go wrong. You are showing me 30 degrees this side. So if you want to show me that, you'll have to move your camera a bit up, because then it's showing me down. Please understand that. So this is a 30-degree scope. A 0-degree scope will look at straight. So if I'm doing this, it's showing me straight. If I'm doing this, it's showing me straight. You get what I'm saying? This is not showing you straight. But this is what is good to go around a corner, look around my corner, and I look around and I see round a corner. I can't see round a corner in a 0-degree scope. If I want to see round a corner, I'll have to do this. And you don't have that kind of space to do that inside an abdominal cavity. There is a fulcrum here, understand? So when you're doing a fulcrum, when you want to see round a corner, you go round like this, you go round like this, but you have to make sure that the view is as per what we want. Are we understanding each other? So this is the camera head with the scope connected, okay? The camera head, the CCD, you can have what is called a single chip camera or a 3-chip camera, okay? With the camera changing to 3-chip, your color improves, not resolution. The resolution improves on whether it is SD, standard definition, or HD, or 4K, or 3D. So that is changing the definition. But 3-chip, 1-chip, single chip changes color, quality. Okay? So when you're looking at the spectrum of color, you know you have the Vigbure, which is the colors of the rainbow. Am I right? So you have V, violet, and you have R, red. Out of this, understand the V is the very thin color, and the R is the obese color. It's a very dominant color. Just remember that. R is the dominant color. Beyond R, you go into infrared spectrum. Beyond UV, you go to ultraviolet spectrum. Are we understanding? So the wavelength of the R is very big. The wavelength of the V is very narrow, and the ultraviolet is even narrower. That's how it goes, the spectrum of the wavelengths. Are we understanding? Now, why am I telling you this? Because this wavelength of R being very big is also a slow frequency color, and it's a very dominant color. When you are in there, it dominates over the blue, the green, the other colors. So when you're in the abdomen, if there is blood and it's a lot of blood or red in there, you will not see. It suddenly becomes dull. The view changes. It becomes dull. So if you want good quality, you should allow to have the surgical planes clean. Don't stain them with blood. When you stain them with blood, you will not get a good view. Are we understanding? So that is very important. When in presence of blood, everything gets spoiled. The whole thing starts becoming red and your quality changes. So you'll have to go waste time to start cleaning and start drying up, etc. Got it? In a single chip camera, actually, red dominates all the time. So it means in that color, you are not going to get a good picture at all. But in red, in 3D and 4K, at least you will still manage. Okay? There's something else we need to understand called white balance. All right? Something else called white balance. Namuel, one of my team members, someone from theater, please. I thought they brought it. So one of the things we need to understand is something called white balance. Now what is white balance? The three primary colors are actually RGB. If you've heard of RGB in many places, red, green, blue. It's called the RGB colors. When you see this thing start, it will give you those lines. What are those colors? They'll always be RGB. You know that, right? You're not going to see a yellow line in it or something. It will be RGB. So this RGB, in equal proportions, 33, 33, 33, becomes white. You've understood? But when there is one more than the other, a little more bluish, then the color changes to bluish. A little more reddish, it becomes a little maroonish bluish. You get it? So when you want white balance, you're trying to tell this camera that this is what I am taking as white in today's surgery. Are we understanding? So when you do that, you have to enamel the cable, the light cable. Let connect, please. I need one of you here, please. When I say connect, unaweka unanisaidia. So when they are equal, 33, 33, 33%, then you pick up something white, lete gauze, connect. Alafu lete gauze moja. Okay. Valentine, you are also team. Come and help. So, you here. Okay, because these scopes and all, remember, I don't like the hangings. Oh, yes, you know my rules about scope. Scope, the light, not that. That is okay. Leave this down, it's okay. So, don't let it, all right, hold here. Here is the problem, don't let it bend here. Okay, so what I was saying is, if this is now connected, see now I have turned it on, can you see? So when I'm doing white balance, gauze, that is not white, gauze. Yes, thank you. So now I will have to go and do white balance by telling this now that this is what I'm taking as white for today. All right, give me the green one. So I just want to show you something, all right? So number one, how to do white balance, and number two, white is important. So now, this is white, press white balance. This is white balance. Okay, press it constant when I tell you. Okay, press, leave it. You have pressed zoom, okay. Okay, so white balance, okay. Can you see that written on the screen? Secondly, I can do it from here. So you see when I come here and I press this, it will say white balance. Okay, so what this has done is it has made this white. So now you see when I look at red, it's red, blue is blue, green is green. Are you seeing all this? Bring it closer. So are you seeing these colors? And they are exactly what they are here. Now, I'm doing white balance. Well, this thing is smart. Okay, it has taken this as white. Now look at my colors. Have you seen what has happened? Look, can you see it's a bit reddish, something funny. Now imagine if you did white balance on something like this, or you go into the abdomen and you do white balance. Inside the abdomen, there is nothing white. All right, it's yellowish, pinkish, reddish, you get it, bluish. They're different colors, but not white. So when you go, some people go and then they press white balance inside the patient's abdomen. And then when you look at it, everything has changed, funny colors like this. So now you will never see the actual colors. You're going to see very odd colors. So this is the whole thing I was talking about. So how to do it? Number one, you don't do it this way. Now see what I'm doing. Look at that. Look at the screen. When you're doing the screen, I'm holding a white, yes, but can you see my finger is brown? There is something blue hanging behind there. So when I do this, it will do white balance for this. There. But this is not a true white balance, because I gave it a brown and a yellow and a blue somewhere in between. Are you understanding? White balance should be cover the whole thing with only white. Okay? So you cover the whole thing only white and then you do white balance. Now this is the proper white. Are we getting it? So these small things are very important when you do it. Then there is what is called focus. So we have zoom, we have focus. So can you see the focus is lost? Then I'm moving this and then now I have my focus. When you're doing focus, you don't go and focus from here. Now see what happens here. I can focus here until I get my best picture. Can you see that? But now when I come here, see what has happened. Am I seeing it clearly now? No. So when you're focusing, you focus it at the focal length. Now focal length ideally of a 10 millimeter scope is around 10 centimeters roughly. So I come around 10 centimeters to a distance and then I try and focus to the best view. Now see that? So now when I'm here, it will still be focused. When I'm going, obviously I'm not supposed to look at any organ that is that far. But what I'm saying is when I'm a little far, I'm still focused. When I'm a little close, see, it is still focused. Can you see that? But when I went too close to focus, it focused, but the moment I moved away, it gave me a very blurred picture. Make sense? Easy fold up. So are we clear on that? Any questions so far? So for a 5 millimeter scope, you go in around 5 centimeters and focus. For a 10 millimeter scope, you go around 10 centimeters and you focus. Our normal surgical, operating field is the target organ should be around 15 to 18 centimeters away. So I'm normally operating around that size with my instruments, okay? So the uterus would be roughly that size away from my scope, from my instruments. You get it? So it will work when I have focused it at the right place. It will not work if I went this close to the uterus to focus, then I'm trying to operate from here. It will give me a very blurred picture. So when focusing, focus at the focal length. Are we clear? The other functions of this would be zoom, all right? There is contrast, there is sharpness. So now look at this. I'll just show you. There is white balance, there is light source, there is display of different types, what I'm trying to, there is zoom. So I can actually, if I press this, see now, and I go in, now see I'm zooming out. This one I'm zooming in. Can you see this? So this is zoom, okay? So that's fine. Got it? So you have zoom, you have sharpness, you have contrast, you have brightness, so you can play around with it. Then you have these buttons, okay? Now, a few things that you may need to know about the camera. Brightness, you have to understand, in laparoscopy, you may put brightness at medium. In hysteroscopy, you need brightness at high, okay? Why? Because you're going in a dark cavity. So you need it set at a bit high. When you're talking of cameras, we have experts at cameras here, but I'm also going to take a small class on cameras. When you're talking of cameras, there's something called aperture. aperture of that camera is adjusting. So aperture is how big you have left the pupil to allow light in. When they want to take you in for an examination of your fundus, what do? They put drops and open your pupil, right? But how does it feel when you go out in the bright light? You can't, I don't know, those of you who've had, it's very bright, it's because the aperture is allowing too much light in and your pupil now is not able to constrict whenever the light is bright, okay? So in hysteroscopy, you want to keep a small aperture because it's a very small cavity, small aperture. In laparoscopy, the aperture changes. Now, these newer ones are automatic, all right? But the older ones did not, and not every place has these newer scopes, okay? So you have to sometimes know what to do. Then there is something called shutter speed, all right? That is when you're taking pictures, the shutter speed, you want in hysteroscopy a slow shutter speed. Hysteroscopy is a small cavity, so you want a slow shutter speed because you want it to take a bright picture of the cavity that you have because it's ideally very dark. Where in laparoscopy you want a fast shutter speed, okay? So you have to understand that if there is a glare, that means that the light is entering too much, you will change the shutter speed to fast so that a little enters and it captures. The same thing happens with these cameras. When you're going out these cameras, when you go night mode, the shutter speed becomes slow. It does, and the other one is chick. You get it? So if you have a lot of light coming in and you put a slow shutter speed, you'll not see anything. You'll just see glare. You've understood? So this is how you play around with it. The third thing is another important setting. These are important things because when you want to do surgery and you don't get a good picture, the issue might just be your settings, all right? There's something called fiberscope filter. Now, when you see these National Geographic videos of the ocean, have you seen how clear they are? Do you think those guys go and filter that water so that then they see that fish from that far looking so clean? Because when you go in, you're just seeing things floating here. You know, you can hardly see 20 centimeters away because there's a lot of muck. But look at the quality of pictures they get. You know why? Because they put their fiberscope filters on. So what it does is these small particles that are floating around, even in a very high-end camera, even the air particles that you'll have some things just floating around might be captured on a scope, on a camera, all right? So then if you turn out those fiberscope filters, it filters those and it's looking at what I'm interested in, all right? I'm not looking at what is here. You've understood? So this is what you need to do. In laparoscopy, you don't need the fiberscope filter, but in hysteroscopy, there's a lot of fluid, and the fluid has those particles and blood, and you don't want those things to be seen. You want to see the wall of the uterus. That's what you are interested in, am I right? So if you do that, you get better quality pictures or videos. So this is what I mean by camera. So my friend, one of the important things, know your camera. So if you eventually buy a camera, you should know this camera, these settings. You see how there are so many things. If you look, I was just showing you here, the flip. Look at the button. So I can set into what I can preset these things to be. So it's about understanding. There's brightness. You get it. There's presets I can have. So basically, you're trying to look at all possibilities of understanding and knowing your camera head and your scope, because laparoscopy is vision dependent. I have mentioned this in my principles. If you can't see, you can't operate. If my camera person does not understand this and cannot show me what I'm interested in seeing, Santeto, I will not operate. I will not operate. So sometimes it's good to scrub up, play around with this a bit, understand what is it, play around with this, look around. You're just seeing, okay, so now when I do this, see, I'm seeing that person there. When I do this, understand. Then again, when I'm doing this, what happens? You see, now it's here. You see, what I tell him, show me on this side. I want to see this side. So they do that, but then see, my focus goes away. So as you're doing your movement, you're still keeping that thing in the center. So it means this will be moving and this will be moving. You don't move one, because then it goes away and you'll be like, what am I seeing again? Then again you bring it back. That wastes time, guys. This is what I'm trying to tell you. It's very, very important. All right? Vision dependent. Next, let's go into the light source. Okay? So the light source, hold it properly, is this one. So this light source right now is on and it's only at 5%. This light source is an LED. In the past, we used to have, the original light source was tungsten bulbs. They've even used candles. Then tungsten bulb is those ones with the filament. The next one became the halogen. If you have heard of halogen bulbs. Okay, but they are very warm and they even get hot. The third one was the xenon lights. And now we have LEDs. So in different hospitals, you'll have different light sources. All right, you need to know what you have, because you need to know whether you have a cold source of light or a warm source of light, or you get what I'm saying. So that is light sources, but the new ones are supposed to be the LEDs. Okay. The same with bulbs nowadays. Don't we go and buy LED bulbs, right? I mean, how many of us are using the filaments? I mean, they're there, but still, that's not the choice. They are even high energy consumption. LED is cheaper. Yes, it's more costly when buying, but it is cheaper over the long run. Make sense? So we are going into the light source. Let me not go into too much detail. Then let's go into, disconnect this. Let's go into the light cable. So light cable, I want you to see what a light cable, this light cable. The light cables, we can have fiber optic light cable and we can have what is called gel cable. So light cable, which is called fiber optic, has fibers inside. Can you see this? Look at this. These are fibers. Now, turn this off. Reduce the light there. So now I want you to see what happens. See, okay, that's enough. So this is a light cable that is damaged, and therefore I decided to dissect it. Okay? I mean, sometimes you have to use imagination. What the hell is going on inside this thing? I don't know. So we decided to open it up. And now when you open it up, you will realize, see, this is how it is. Inside here, look at all this. They are all small fibers, all right? These fibers, each of them has a light at the end of it. Get it? So if sometimes I even try to break these cables and pull them out. They are very, very fine tip. All right, so this is it. But this is a glass, it's a glass fiber. So if I take only one of them, it's like a hair. You'll hardly even see it. Look, you turn on this light now. Now look at this. I have one small fiber here. You can hardly see it. Can you see it? It's in my hand. When I do this, you cannot know there is a fiber on this. Okay, but this is how thin this fiber is. Okay? Can you make out? So that is a fiber. Okay? And this fiber is all the way from here to here. So the transmission of light is almost 100% because it transmits it through fibers. So whether it's bent, remember we learned in physics, light travels in a straight line. Okay? So when I do this, light will break. Light will not transmit unless it's fiber optic. Are you now getting it? Otherwise, light cannot travel through a corner. It will. So by the time you are operating, unless you have a straight thing and then you're now doing that, it won't work. which cannot happen. So for laparoscopy, we had to work with fiber optic cables. You've understood? Yeah, here. Pass it round. By the time it will reach there, it would have been lost. But you just assume it's there because no one will know whether it's there or not. They'll say, yeah, I have it, but it might be lost. So that's a fiber optic cable, guys. All right? So you now see what happens in here. Got it? Now, why am I showing you this? Because how to handle this? You see why when I was even demonstrating you, the first thing I asked is my assistant, come and hold. You get it? Why? Because if this thing is bent like this, you've broken these cables. Okay? So, let's go and now see this other one. Okay? Shika hivi. Hapa innocent. Shika tu hivi. So can you see? It's transmitting here. But can you see this? Look what's happening here. There are a number of places where you see white in between. You know what this means? This cable is broken here. All right, these many cables are broken here, another one is broken here. They are all broken in between. There's one broken here. You get it? So when you turn this, if you turn everything light off, you'll see so many small breaks in this. There's one break in here. So wherever it's broken, it will submit the light there. So that means that much light is not reaching here. You've now understood. So the moment more than 30% of these fibers in here, these are all individual fibers in here, the same thing. But this is a transparent outer, it's for training. It's a transparent outer this. So it's just to show you that this is how these cables transmit light. You've understood. So when more than 30% of these fibers are broken, that cable is not good enough to operate on a live patient. You understood? If it is more than 30%, it's not worth operating on a live patient. It's not going to give you enough light transmission. Connect ours now. So how do you know it's 30%? One, you will not see anyway, so you'll see very dull pictures. So you'll know something is wrong. But two, this is how we would want to test it. Okay? So this is when connected. Now, I want to, can you see this? Can you see the light? Now, you can't, right? See what happens. No, look at it now. Can you see? Can you see the light transmission? Yeah. Can you see? So this I've blocked transmission. This I've left it. Just in the open. Can you see? Okay? So it transmits light even without. So when you're supposed to test it, you just lift it out like this, not to a very bright surface, because you'll hardly see. Yeah, you go to a light, not a very bright picture. Yeah, like this. So that light is good. This one is too bright. When it's too bright, it's already glaring. You can't see. Look at that. Okay? So what you do this, you do that, and now what you're trying to see is how many black dots you can see. Come and see, guys. It already has black dots. Can you see some black dots? All right? See what happens when it's glaring. You can hardly see. Can you see it's glare? Now look at that. But can you see some small black dots? Got it?
Yes.
Small black dots. Ebu weka camera. Connect the camera. That one don't remove. I just leave it there for now, please. Huh? Bring that camera here. Shika hivi, somebody. To that. I don't know if we can. Shika hivi. Innocent. And my scope. I just want to show you on the screen so you can see better. Okay, so now, can you Put it away to a lighter, yeah, don't. Can you see some black dots on that? Now, that tells you, even my own team here, which is supposedly experts at this, are still damaging cables. Okay? Innocent. That is us included. All right? So, it happens. It's inevitable. But this is probably not yet 30%. I mean, it's not 30% of it obstructed. You understand? The moment you get more than 30% black here covering that field, that cable discard, replace. You've understood. So this is how you test it. You just test it in normal light and you check. Now, when storing, this is what I said. You store it like as though this is a very sensitive, you know the way, have you seen snake charmers in India? All right? So snake charmers keep their snake inside a round thing where they actually go and put their snake nicely like this. All right? How many of you play with snakes? Okay. So you put this like this. You take large circles and then you store it like this. You go in and store like this. Have you understood? No bending. Because this thing is like it has a spine there. So you don't break this, otherwise you break the spine of this instrument, of this snake. Are we understanding? This is how this thing is packed. So you don't pack it into small, tight, compact things, spaces. You pack it like this, very, very, very large. Now this cable will live a long life. The moment you do that, this cable is gone. All right? And that is very important. All right, so we already have more than 10-15% breakages. So tell them to be careful. This is very key to me. The other thing is when they connect it up here, this is where again it gets damaged. This is what I was trying to show. This gets damaged. So ideally, how do you hold this camera? You're supposed to hold it like this. You get it? So you see now I've left a big like this. You don't leave it hanging like this. This is breaking here. All right? So you hold it wide. All right? Santeto, Valentine. This. So now you see, now I am having it a bit more control with my hand. Are we getting it? Let's check. Yeah, pick it. I'm in theater, tell her. So far, any questions on cable, camera, light source? We are done, right? The monitor, obviously, I mean, we've discussed, these are special monitors. They are not regular TVs. These monitors are extremely expensive. This thing is almost $1 million plus, okay? So they are not the regular TVs. They are not LED TVs. They are not, no, this is way above that. All right, but obviously, I mean, monitors, it depends. You can still work with, people have worked with simpler monitors as well, okay? Now let's go to insufflator. The next topic is insufflator. The insufflator is needed to insufflate the abdominal cavity, which is normally a vacuum, into a space that is filled up with gas to allow us to operate in there. The gas in our case, or most regular situation, is CO2. We'll go into CO2 and why CO2, why not others when we reach there, when we discuss the carbon dioxide gas. But right now we're discussing the insufflator, okay? So the insufflator in the past has been divided into an analog insufflator, a digital insufflator, and a microprocessor controlled insufflator. This is a microprocessor controlled insufflator. The insufflator has a couple of gas supply. All right, no, it's okay. I don't know why it has finished. Let's follow up on that, okay? The insufflator has a couple of sets here. So this set has what is called pressure setting and a flow setting and a volume setting. Okay? The pressure setting is described as preset maximum pressure. Preset maximum pressure, which means now I have preset this at a maximum pressure of 15. Are we clear? The next thing is I have what is called an actual pressure. So when I turn this on, see that? When I turn this on, this is now telling me different setting. Can you see this? So this is the actual pressure. When I block it, it goes high. When it's, you see now I'm allowing. And this is the preset max. Got it? The same thing with preset maximum flow rate and the actual flow rate. Are we clear? And the last thing is the volume of gas used. That is this one. Can you see this? 0.1 liters so far used when I turned it on now. Okay? So these are your 5 parameters that you know here. Preset max pressure, actual pressure, preset max flow rate, actual flow rate, and the volume of gas used. Of these, the most important parameter is the preset max pressure. Preset max pressure. That is the maximum intra-abdominal pressure that you are insufflating into that abdomen as you're operating. So in an adult, a normal adult with normal BMI and most common cases, your operative preset max should be 12 to 15. You don't operate above 15 in normal situations. Yes, you can, when entering, if you're using Veris, I told you about it there, you can go and put in at 18 or 20 and distend it well, make it tight, then put in your primary ports and then bring it down to 15, 12 to 15. But operative pressures are 12 to 15. The second one is in obese women, or obese people, you can, in bariatric surgery, you can go up to 18. In pediatrics, you can go 8 to 10. Okay? In adolescents, 10 to 12. In neonates, it would be much lower. It can be even 6 to 8. You've understood? So basically speaking, these are some of the pressures that you need to understand as you are doing these procedures. Are we clear? Now, actual pressure will keep on fluctuating. So it's the actual pressure. What I mean by fluctuating, if you have a leaking trocar, it will come out and the actual pressure will go down and the pump pumps more. But it tries to maintain, you're telling this pump, that's why it's called microprocessor control. You're telling this pump, you maintain 15. So when you're sucking blood or sucking air, it goes down, the pump pushes in, makes it 15. You've understood? When it's leaking, it will try and keep on pumping. So you should ideally work with trocars that don't leak, ports that don't leak, because otherwise you're going to use up so much gas and you'll finish your gas, all right, regularly. So those are some of the ways. And when sucking, sucking you may not have a choice, but don't suck in air. If you're supposed to suck fluid, the blood, all right, then go into the blood and then suck the blood. Why are you sucking in the air and then everything is just collapsing on you? You've understood. It wastes a lot of time. 2, it collapses the cavity and bowel touches the scope and you'll have to come out and clean it 5 times. What's the point? You're wasting time. The surgery is being stopped now and again. So when you see experts operate, you'll see their cameras hardly come out. They don't get dirty, they don't touch things, you get what I'm saying? But that tells you that that team knows what they're doing. And then you start working with people who don't know what they're doing, and every 5 minutes they're cleaning the scope. What wanna check up? All right? But that tells you that, guys, this team does not know what they're doing. And it reflects back on the surgeon as well. This surgeon also doesn't know what he's doing. But hello, it's not me, it's my team. But that's what I meant, that teamwork. Laparoscopy is teamwork. So you have to be careful, guys, all right? you have to create an image for us as well. Don't spoil. Bana CV, usiharibu CV. Umeelewa? When people are seeing, they're like, look at these guys, bana. They don't even, every 5 minutes they're cleaning their scope. But you get my point? So, taking care of your camera, not touching things, taking care of the suction, not collapsing the gas. That's how we need to operate. You get my point? So this is what I meant by this. The third one, flow rate. So flow rate, you start off with low, then you increase. And when you're operating, you can go, this is a max of 50, you can see. You can go up to 20, 25, 30, 40, I don't care. What that means is whenever whenever you're sucking gas and it collapses, when it's high flow, it will pump in very quickly. All right, so you will maintain a good pressure all the time because the pump is told pump in very quickly the moment someone sucks out. Okay, so when operating, don't go operating continuously with a low flow rate because then you'll suck a little and everything just goes zoop, collapses on you. You've understood? So those are some of the things that people don't understand. So your team should know how to play around with these settings to give you that, okay? So how do we set up some of the tips again? I like giving tips. Number one, you normally have a filter that filters this. You have a heater that can warm the gas so that you get gas that is warmed. This is compressed gas, CO2, so it is cold. So you can warm it as it goes in. You've understood? Then you filter it so you remove any impurities. Mostly they don't have impurities, but still it's safer to purify. The second thing, whenever you're connecting, you connect it and purge the air out in normal situations before you start. So what I mean is, you'd come, connect the tubing, start to, so it pushes the air out. Because remember, this is not CO2 until it has been pumped out, right? So purge a little bit out, then connect it. So whenever you see me start, right, my team, whenever you see me start, what do? I turn it on, I will feel that the air has come out, I'll feel the air pumping against my ear, and then I'll connect it. You will not see me connected directly in. Have you seen me connected directly in ever? How many people have done that? Yes, they regularly do. I say connect gas, the first thing they do is they come and connect the gas. I'm like, but that is now air. This tube still has air. You're not doing surgery with air. You're doing surgery with CO2. Test it. Then connect it. You get my point? Purge the air out. The third thing, try not to, connect, like when you're putting varies, don't put in varies with the tube already connected. Remember, we put in varies with the valve open and all, but it was varies alone, not with the gas. I've seen some people do that as well. They have the varies, they have connected this, now they are going to put in the first thing. I'm like, again, that's not the way it should be done. All right? So don't learn wrong things, learn the right things. Put it, do your safety test, you've checked it, now connect, remove the air, then connect it here. Simple? Got it? The third thing, this pump actually pumps it in a pulsatile way. So when you connect it and you turn it on, it will not be psss, it will be zip, 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 zip. You get what I'm saying? It's pumping in air. So you have to understand that it is a pulsatile insufflator, okay? Check your settings before you connect. Always. And when I mean always and I say check, who is to check? The surgeon verifies. I have not ever started a laparoscopic surgery or a hysteroscopic surgery without verifying these settings myself. Are we getting it? That is safety. Guys, if you rely on your team and this thing is put at 30 and you don't know, my friend, you're asking for trouble. You get my point? Some of these settings you check yourself, which means you need to know them yourself. Make sense? You cannot afford not to. The next one, when you've started, recheck your settings after you've put in and readjust them to the ones you want. So I told you, you can start high pressure and then bring it down to 15. Okay? 2, you will start low flow rate, but then bring up the flow rate to high so that you can allow for the sucking and all that stuff. Got it? So you will be changing it. Okay? If the flow of gas here is very rapid, which means it's constantly pumping in, all right, and it is to try and maintain the pressure, this thing is constantly doing bzz, bzz, bzz. It actually makes noise and tells you it's constant. What does it tell you? There is a leakage, all right? So look for the leakage, because that means there is a leakage. It's leaking. So that's why it's needing to constantly pump in. You've understood? So look for the leakage, solve the leakage. Okay? Then, yes, I mean, we have discussed about the positioning and all, that is okay. CO2 gas. So let's go into what we use now. So this is a cylinder. We have a centralized CO2 as well, but this is now connected to this cylinder. So the CO2 gas, or let's say the insufflating gas, the CO2 gas is used because of certain reasons. Why do you think we use CO2? What are the positives about using CO2? Anybody? Start making guesses. It's not combustible, very important. Imagine using oxygen in there and then using bipolar, and you see a spark and then the abdomen, patient is on fire. All right? So you can't use a combustible gas. Agreed? Okay. So non-combustible, very important. Next, it's absorbable. All right? So you've heard of CO2. We produce CO2 as a byproduct anyway. So we can absorb it. And secondly, we have a way of expelling it through the breathing, through the lung, right? That's where it exchanges. So even if there is a slight more insufflation into this abdomen, that some of it is absorbed through, and it does, absorbed through the peritoneal cavity or absorbed through through extra peritonization out into the vessels, you actually can still absorb it and expel it through the ventilation that you have connected. Got it? So it is safe. Okay? Third, affordable. So it's cheap. Okay? It's not a very expensive gas. Fourth, what color is it? Imagine working with a gas that is blue colored or yellow colored or white colored smoke. Can you work with those gases? So it has to be colorless. All right? Yes, many colorless gases are there, but there are also many colored gases. Agreed? So we are not using a colored gas here for that reason. Okay? Anything else? It's not smelly. I mean, imagine you operating throughout the day with a very smelly gas. All right? I mean, you walk into that theater and be like, okay, I'll see you tomorrow. Okay? So you get what I'm saying? You don't want a smelly gas. You don't want a toxic gas. Not only is it not smelly, it's also not toxic. Put on the AC. All right? So are we getting that? So this is one of the reasons why we are using CO2 gas. Another thing we have to understand, CO2 gas, we normally now, this one we are using a cylinder. So this cylinder is meant, how is a cylinder meant to be placed? Upright. A cylinder is always meant to be upright. CO2, oxygen, nitrous. Are you supposed to put them this way? See what even my team does here? Okay? So, where is my team? Yes, my team. They disappear on me. All right. See how this CO2 gas has been put. This is wrong. Okay? This CO2 gas, and this is wrong, but more wrong is if this CO2 gas is done that way. Meaning, upside down, you are in problem. Because this CO2 many times is actually, when you compress it, it gets some liquefied at times. So when you do that, you actually can push in the liquid into this machine and it will clog the machine. It will mess the machine up. Are we understanding? These CO2 gases, even initially, we had put it somewhere upright, we were hanging it, tying it. Now, nowadays, we don't use it. This is just, I think I'm using this cylinder after a year. Why? Because we have our own CO2 plant up there, meaning we have our cylinders upstairs in our gas plant. You've understood? So we don't use this. But apparently, over the weekend, we had that gas finish. That's why we are doing this, okay? So I don't want this again, and as I've said, this thing is meant to be upright, please. Huh? It can't be like this. It's dangerous. Watch us say. And this can never be lifted up. That cannot be lower than this. Okay? Now, I was talking about different scenarios. I think that is different. So we have now done with the insufflator, we have done with the processor, the light source, the hysteromat we will do in hysteroscopy. Energy we will do with our energy talk. Okay, I usually do an energy talk. I'll explain to you in that. All right. So those are the settings we have. Any questions so far in this? If I am to go into details, guys, I've not finished everything. But some of these things I'm teaching you are to give you the principles correctly. Right? It's very simple for me to take a 10-minute instrument and equipment talk. Frankly, I can finish it in 40 minutes in one talk. I just name this. Insufflator for gas, this for this, use this much. But if you have seen, I go into breaking down the details because you need to know why is Dr. Yamal saying this setting? Why is that setting important? You get what I'm saying? I think those are the things that are very important for you. It's not important to know the names and important to know just the numbers. You will forget it, all right? But if you're told why, you will never forget it. I don't think I need to look at any of these things and read about on it at all. I mean, and that's how I work with every single aspect of teaching. I don't need to go back to read. When you see me look at this, I'm looking at it for understanding what points to not miss out when discussing, not to see what I want to teach you, or not to get figures from there that I have to think this is 18, this is 15. Those things are here now. They are in this hard disk. Are we getting it? I don't need that. But the reason is I understand. When you understand, you don't forget. You can teach. When you don't understand, you mug up, you cram. You will cram for a day, you will cram for exam. The next day, you will have forgotten. Don't cram. Understand. All right? You'll never need to ever. And that's what I mean even in anatomy, even in my surgical steps, even in the principles. I don't cram. I understand why. And once you've understood why, you will never forget in your life. You will pick up, you can today tell me to give you a lecture on any topic in our obs-gynae field. I will pick up the topic and I'll break it down for you. I kid you not. But the reason is I've understood. You've understood? I've not mugged it. I've understood. So please, guys, when you see me going into these few details, it's not because I'm trying to give you too much information, but I'm trying to give you the logic. Once you get the logic, you'll not forget. Whether I ask you 5 years down the line, you'll not have forgotten. That's what I want. You've understood? Good. Any questions? So I think we don't need to go into those other things. Yeah, smoke evacuator. I think maybe because that one I know I'll not touch again. But smoke evacuator is to excessively. I mean, when you're using energy, and you get smoke. Smoke has a number of issues with it. Number one, it affects view. All right. Number two, it is carcinogenic. And trust me, it's very dangerous, but we do that day in, day out in our field. So ideally speaking, working with smoke, that you just open up a valve and release into the air and then everybody is breathing that smoke is an unhealthy practice, okay? So using a smoke evacuator that actually takes it up and the room still never smells of smoke is the way to do these things, all right? This is not normal smoke of vegetation burning. This is tissue smoke of tissue burning. And people have even found out of some conditions or diseases that can spread by smoke particles, including warts. Do you know warts when you excise them? If you excise them, my friend, you can get warts inside your respiratory tract. It has been proven because it's a virus. You spread the virus through, you think that smoke is killing all the viruses? It's releasing some viruses as aerosols. Okay? And that's why in COVID, we were told to be extremely careful with smoke because we did not know whether it was spreading or not. But there were some reported cases of something like that. But we did not know. We already know of certain diseases that spread by smoke, like HPV, all right? Warts, it spreads by smoke. So when you're excising those things, you guys are very happy just excising and breathing that smoke. Ideally, you have to be very careful. Put a suction there and smoke this out, all right? And make sure you're never without a good 3-ply filtered, mask. Don't play around with that smoke, okay? So this is what I meant. It is carcinogenic, it can transmit infections, it spoils your view. So there are many negatives about it. So ideal situation, you should have a smoke evacuator, okay? And if you're not having a smoke evacuator like in open surgeries, then you should have the suction cannula that is just over that area where you're buzzing. So you buzz and it takes the smoke away from the field. That's good enough. Got it? Good. Any other questions? I think that I've covered all of it. Questions? Good. So thank you. We meet back on maybe Friday. We'll confirm on Thursday or Wednesday. We meet back on Friday in the conference room. Okay? Thank you.